Welcome to the Auburn Medical Group YouTube live stream, the entertaining medical live stream where viewers can ask real-time questions of real medical doctors. And here are our hosts, Dr. Mark Vaughn and Dr. Gwen Vaughn.
And we're here. Welcome, Dr. Gwen. Oh, yeah.
Hello.
I can actually make it show our names.
That's me.
Dr. Vaughn. Dr. Green Knight.
Yeah.
Welcome to the program. This is the Auburn Medical Group live stream. Today we're talking about biologics for atopic dermatitis.
Very specific biologics.
It's a very specific topic.
There are a lot of different biologics
for
out
something
there.
that we don't prescribe.
We can talk about other biologics as well, which we are acquainted with and kind of know our patients that are on them.
I don't have as much. Kind of leave it to the specialist. But let's get to our comments and questions because our audience, you have been active before we even turned on the button to go live. We're already having the chat going back and forth. So, well, first of all, we have to bring out that Lindsay Antwine had already, before the show even starts, gives a $25 super chat. So,
that's a kind
wow, thank you.
All right.
So, you are welcome. Thank you for the super chat. And then, of course, we thought that was awesome that she did that. Laura Webb is greeting us, as is, Hilda Bauer is greeting Lindsay, and Bianca is greeting us. Hello, all.
Hello.
We love having all of you here. We love the familiar faces and names. We love the new ones, too. So the topic was biologics. Maybe a lot of people, I would guess most of our audience probably hears that word and wonders, what do you mean, biologic?
Biologics, yeah, it is kind of
Aren't all the medicines somehow biologic because they work on...
They work, but I think biologic refers to how they're made. If they're made in living organisms, biologic. So that's how these are got their general. So actually, insulin would technically be a biologic as well. But when we say the term biologic, we're typically referring to a very specific subset of that.
If insulin was a biologic, wouldn't it have the C protein?
If it were made in, not if it were made in, made it that way on purpose.
My understanding is, how does this go?
Because it's made by bacteria and but not anymore. I mean, now they make it synthetically, but originally insulin was,
Okay, forgive me for not knowing the science better than I do, especially when I'm a doctor and I should know this stuff. But I have this memory of a wife killing a husband with
insulin,
exogenous insulin. And the way that it was proved, okay, start over.
Set the scene again.
This is how I think the story went. That it was what do you call it when you do it to the kid and bring him in? Munchausen's by proxy. Munchausen's by proxy. So this is
not just the name of a band.
That's an awesome band, yes. Hello, Rodrigo. I can't think of any of their songs.
Yeah, I don't know. Either.
Midnight Booty Call or Don't Call Me at Midnight, but if it's 11:55, that's okay.
I don't.
Does anybody else know the song we're referring to?
Don't remember.
By Munchausen's by proxy. So the story goes that the parent who was suspected of doing it would bring in the child and would keep having these low blood sugars. And so the question is, do they have, like an insulinoma or something, some kind of biologic problem causing them to have this this elevated insulin level? And what you could do is
test to see.
Check to see if there's the C protein. So when insulin is made by your body, you've got these two strings that are a part of the insulin. Insulin itself is a protein, right?
Yeah.
But they're connected by this, I guess, inactive C protein, but you don't need that.
You don't need that. That's why
the body makes it. It's there
when with the synthetic protein that we inject.
So they're able to prove that it was being injected into the child because it had or didn't have the C protein. I'm guessing didn't have.
Did not.
Whereas if it was actually the child producing the insulin in their own body, it would have had the C protein.
Right.
So
yeah, we sometimes use that.
I'm sorry.
We're getting a little off course because I brought up insulin.
I thought that was an interesting little anecdote.
The C peptide, C protein was something that was used to see if is this in fact type 1 diabetes versus type 2 diabetes. Are you producing your own insulin? Anyways, that's separate.
Because you think that they're doing it to themselves?
No, because then you can see if they're making their own, if you're making exogenous or making
while you're treating
protein.
them.
Yeah, while you're treating. Yeah. Anyways, back to biologics.
Biologics.
So when we talk about biologic, we talk about a fairly specific subset, which is antibodies against something. To treat typically inflammation. That's where these kind of got their, found their little niche. So some of the older ones, Humira, Enbrel, those would specifically, it's an antibody that targets one of the inflammatory molecules of the inflammatory cascade that causes inflammation in the inflammatory condition. So this is a lot of the rheumatoid conditions, rheumatoid arthritis, lupus, things like that. But we are starting to find that it works for pretty much anything that has that inflammatory cascade. And then new ones came along that targeted different parts of that cascade, interleukins specifically, which we'll talk a little bit more about. And that's where some of these newer ones came out that treat atopic dermatitis.
So it sounds like you're describing conditions that in the day would have been treated with just steroids
that was kind of all we had.
Your giant big gun that you use to hit inflammatory state.
Yeah.
But now we can be a little more targeted, a little less side effects.
Right. Yeah. We'll talk about some of those side effects probably. What comes with these antibodies targeting.
Right. Monoclonal antibodies.
Yep.
Monoclonal meaning a single kind of antibody, not lots of different antibodies, right. Which would be like immunoglobulin, right? Shots that people used to get in the. Well, I think I still got one in the 90s
for. Rabies?
A trip to New Guinea.
Oh, okay, yeah.
Just to kind of, because they didn't. Well, I already had my Hep B at that point, so.
Hepatitis, maybe.
Yeah, I'm not sure what they thought they were treating, protecting me against.
Who knows?
I don't think I do remember that they would say to give immunoglobulin if you had like a needle stick and somebody didn't have.
Yeah. You get that going
I think
early.
we still do that, don't we?
Not for needle sticks. We just get you started on.
Yeah, I was just thinking
other
Hep C.
medications. No, we got different medications for Hep C these days, so we don't use immunoglobulins.
Oh, we actually have a treatment for Hep C. That's why we're screening for it, because we actually have a treatment for it now. Thank you for reminding me. Okay, Lindsay Antwine is on, and she says, "I love a good steroid." At
Me too.
17, I was on methotrexate.
Good old prednisone.
And it was methotrexate is not a steroid, by the way.
Yeah, that was sold differently.
Stay on it long term. Okay.
Yeah, so methotrexate is not a biologic.
Nor is it a steroid.
It is an anti-inflammatory that is used for those autoimmune and other conditions, though. But it does have its limitations. It's kind of weird. You take it like once a week, and you have to kind of dial in these doses. But if you take it, you're actually, as soon as you start taking, you start accumulating the cumulative dose that you can get. And if you get up to a certain amount, you've got to get a liver biopsy. Like, liver problems are so common that if you get up to, I don't prescribe methotrexate, so I think I have one guy on it. So
it makes it easy.
So I don't know what that dose is. It's like 1,500 milligrams or something like that. Once you get to that dose, you got to get a liver biopsy because it can be hard on your liver. So most people, that's helpful for a little while, but not a good long-term solution.
Yeah. So I was just going to fill in a little bit of what Dr. Goodwin was talking about when he says inflammatory, and these are antibodies against that. So there's all sorts of little chemical messengers being released by cells all the time for all sorts of different reasons. And one class of them is called the interleukins, shortened to IL, and usually they'll be numbered. It'll be like IL-4 and IL-13, and not aisle like in the store. Clean up IL-13.
Interleukin.
IL-4, IL-13. Yeah. And the one we're talking about mostly today, Dupixent for atopic dermatitis, is well, I can actually look it up again here. So Dupixent is one that goes after IL-4 RA. It's a longer name than most of them. And that's in contrast to another one that's also used for atopic dermatitis. There's at least two of them. The other one that's popularly known is tralokinumab, and it goes after...
What's the other name for that?
IL-13.
Let's look that up.
Directly. The Dupixent one, actually, the one it goes after is one that signals for IL-4 and IL-13.
Adbry is the trade name for that.
Adbry, of course.
Adbry. That's easier to say than tralokinumab.
So the MAB, you'll notice that they have a similarity. They end with M-A-B, monoclonal antibody.
What?
So that's
the generic names all end in MAB if it's one of those biologics that we're talking about.
So there's actually a drug name that makes sense, and that's the MABs, because they're all monoclonal antibody. And you know, because you just look at the generic name, you go, that's a monoclonal antibody against something.
Right.
And somehow, I guess this IL-4 and IL-13, that these two specific ones go after, are apparently really active in a big part of the symptomatology of
atopic dermatitis.
AD.
I don't think I've ever heard atopic dermatitis called AD before.
Okay.
Because it's way too close to ED, which is something else.
I bet if you were a dermatologist, you wouldn't say that.
They probably don't treat a lot of ED.
No, I don't. No, not really. I don't think a dermatologist would.
Oh, yeah. So one of the things we need to talk about with these medications, they're monoclonal antibodies. So they are antibodies that are being put in your system. So they do have some risks with that. They can affect your immune system. So before you start any of these treatments, which is any of the MABs, you should be tested for infectious diseases that can kind of rear their ugly head.
Get your PPD.
Yep. So you have to get a PPD, which is to make sure you don't have tuberculosis. You get tested for Hep B, Hep C. Make sure you don't have any of those kind of simmering in your body. I don't think you need to check for HIV. That may be another one. But all of those kind of chronic infectious diseases we check for to make sure that getting this treatment is not going to put you at risk for one of those popping up.
For it coming out.
And then while you're on the treatment, you can be at risk for infectious diseases as well. So it is something to look out for.
I was looking through the adverse effects, and I noticed a pattern. And it was viral infections and helminthic infections, or worms.
Helminthic. Those are fun.
So those are what you're at risk for if you're on these.
Yeah, viruses and
the herpes breaking out, or
we don't get many worm infections.
Getting worms
in the United States. That's not a huge,
away from the
huge
cat.
risk. But viral infections, going into your winter illness season, you are at higher risk of getting all those viruses.
But it's probably not as bad as if you were on prednisone or some
true. Yeah, and the
steroid we used to use for this purpose.
And prednisone has its own set of side effects, and that's why we don't use it long term. They are way worse than any of these monoclonal antibodies, and they can have long term effects.
She's putting us to the test here.
You ready? Okay. Sure.
Okay. All right. So first of all, Lindsay says, "Yeah, I know. It doesn't."
Oh, she's talking about the methotrexate. It's not a steroid. She knew that.
Yahtzee's greeting us. Yeah, Yahtzee. Lindsay again says, "I just want my immune system to calm down."
Don't we all?
Yes. And then here, JAK inhibitors. What?
I'm trying to think what the JAK inhibitors.
JAK inhibitor.
Okay, now
I'm going to Google.
Think of the names because we don't prescribe these. So we're
going to Dr. Google here. JAK inhibitor. I'm trying to remember.
I was going to talk about
What's
the TNF alpha inhibitors, but the
JAK inhibitor. You're really putting us to the test.
What are the drug names for that? I think those
kinase.
I think those are monoclonal antibodies
should
as well.
Should I share this with the audience here so they can see what I'm reading here?
Google. So that's what he's reading.
Yeah, I do have a preference for my search engine.
Okay, there we go. Here's some names: Xeljanz, Alimin, and Rinvoq. Yes. I have heard of those names, and I do have patients taking those. I think those are second line, though. Again, we're not rheumatologists here, so this is a better question for a rheumatologist or a dermatologist or whatever.
Yeah, if you are one, please chime in.
System you're treating. It is my understanding that those are second line to the IL inhibitors or the TNF-alpha inhibitors that are different monoclonal antibodies. It could be that for some reasons that they're kind of they're kind of bubbling to the top as being more useful. But yeah, we don't prescribe these. We see people that are taking them, and we just defer to the specialist.
Or whatever system is involved.
Right. One of the things you also need to think about when you're on these monoclonal antibodies is your body making antibodies to these antibodies that are coming into your system. So often they will put you on another medication while you're taking these. Imuran is a common one that you take to try to prevent that. So it's not just like you take this medication, often you take another medication to try to prevent an antibody building against that antibody to make sure you can take the medication longer. And depending on the illness, some of these are long-term. Some people take these for years and years. Sometimes they are short, and then you try to wean off to see if you've gotten some more remission from the treatment.
All right, let's see what. How about what Robert Antonio says? Do the MABs suppress your natural immune system?
Yes. Yeah.
How?
Yeah, how is a great question. I can't say I know the reason for that, but they say that you are more at risk for any viral disease out there. So
because you don't have the inflammatory component.
That could be why.
Illness.
Yeah, that could be why that you're just not able to mount the same response.
The interleukins are being blocked.
Right. Maybe some competition there between your natural immune system.
Supposed to address the cytokine. So that's what he was talking about. The ILs that we're talking about that get released are some of those cytokines. Cytokine cell actor.
Sure.
Is that kind of what it means? Yeah. Yahtzee has something here. What is your recommendation for pressure-induced skin out? Pressure-induced? Itchy wheals. Is that how you spell wheals? On skin when pressure by shopping bags on wrists. Patient has asthma, alcohol redness on body. Patient is Chinese.
Chinese can have Chinese specifically can have some interesting reactions to alcohol. I know that.
Oh yeah, decreased alcohol dehydrogenase.
Yeah. So they get the flushing that can happen. Right. But as far as it sounds like you're talking about a topical allergy. Pressure is kind of interesting there, but probably a good thing to discuss with a dermatologist. So a little aside from what we're talking about here.
Actually, something does come to mind when I read this, and that's the really, really interesting things like chronic nasal allergy. Yes, topical.
Yeah. Atopic person.
Different types of urticaria, like
there are different
cold urticaria or heat urticaria. Have you heard of these or seen them?
Yeah.
Cold urticaria, you test by just putting an ice cube on the patient's skin, and they get a wheal
of urticarial reaction.
It gets elevated, red and itchy.
Yeah.
Right where the ice was. So pressure causing that same reaction does not seem too removed from that kind of reaction to me. Never. I don't know if I've ever seen it. Oh, I have seen. Now this is interesting. I wish I could show it to you. I had a patient. She used to demonstrate it. She's since died, but when she was our patient, she had dermatographia.
Yeah, that's an interesting one.
So she could take her fingernail and write on her skin. And then you do something during the visit. This would be something we do like for a medical student just to show them. The patient thought it was cool enough to share with the patient, so she would do this to her, put her body through this. So she'd like scratch letters on her arm when we came in, and then by the end of the visit, it'd be in red raised lines on her hand or arm, wherever she did it.
She should have written like the name of the student and then like some spiritual experience.
I was going to say, well, that's exactly it. This is what was seen as stigmata type events that people would do. I guess a true stigmata would be the wounds of Christ, on the wrists or the feet. They'd replicate that because it would appear, the priest comes in to do the exorcism, and this would show up.
Just
or words, just profane words would show up after they entered the room.
Right.
And so it was seen as some kind of a demon possession.
Writing something,
Yeah. So, where did I get that from? Oh.
Dermatography.
The different skin reactions that you can have.
Wheels. And the things that can come up.
Yeah.
Yes.
So, Robert Antonio, thank you, doctors. Completely fascinating.
It is fascinating.
Actually, it'd be a lot cooler if we could demonstrate.
Fascinating. Yeah, I can't. Yeah.
No, neither of us have it, so we can't.
No.
We can't do it. So, and the Nazi's also saying the patient is a cardiologist. We're still back to the the person with the wrist straps or whatever.
Physician, heal thyself. Yes.
Yeah, that's right. Okay. Very good. So I hope Lindsay came up with this week's topic, and we thank you, Lindsay, for giving us something to riff on here.
Sure.
And actually, we did. As far as topics go, this wasn't the worst one that we've done a show.
Yeah.
Even though
biologics are an up and coming treatment for many different things.
You're going to be seeing, and maybe not exactly biologics, but other somewhat related technologies coming out. And even though we talk about the immune system concerns with these medicine, I mean, the huge majority of patients, it's well worth it.
The benefit way outweighs that risk.
If you're having really bad disease and these things make it go away, it's better than the steroids. The steroids have other problems besides just the blanket immune suppression. They also have the elevated blood sugars causing diabetes sometimes, psychosis sometimes, the weight gain that you get with the steroids, actual physical changes, like the stria.
Yeah, they are not good.
Way, way, way better than that. I guess they're probably a little bit pricey still at this point.
Yes.
Especially compared to generic prednisone, which would be just pennies.
Yes, literally pennies.
But the risk is, it is real, but...
Yeah, one of the things to consider with these biologics is they need to be administered not orally. So either by infusion or by subcutaneous injection, like just under the skin. Some of them, like you can take home and do the injection on your own weekly or however often you need to do it. Some of them you go into like an infusion center and they hook you up and you sit there for an hour or 2 hours for, every couple of months or so.
I was reading on the Dupiximab or Dupixent. It's 2 injections. You get a box with either one syringe with 2 worth or 2 separate syringes. Subcutaneous. Patients give it to themselves like insulin shots. Mm-hmm. But the box of the 2 injections for the month, if you don't have it,
$1,500.
Yeah.
Pretty good at predicting these things.
I think it was about, I think that's actually pretty close to what it was. That's...
they can be pricey.
Maybe in the future...
I don't think there are any generic biologics. I don't think so. Anyways.
Which of all things
they've been out for a while. Like Humira. Humira's been out for, over a decade because it was out when I was in my residency.
It's getting close.
It's got to be getting there.
All right. Any more comments? Yahtzee, we're glad to have them, but that's
yes, that's the big but.
Yeah, absolutely. Okay, thank you, Dr. Wayne. Very good.
Yeah.
Thank you, Lindsay, for the topic. Hey, thank you all for watching the show. And if you want to hear my song on Spotify or whatever streaming service, it's Dr. Vaughn. Notice there's no space between Dr. Vaughn. Until next time.
Hey, I'm Dr. Wayne Vaughn.
Dr. Mark Vaughn. We'll see you next time. Until then, stay in good health.
Doctors, thank you for another informative session. Auburn Medical Group is located in Auburn, California, USA. Thank you for participating. Please tell a friend and join us again next week.